Good morning, ladies and gentlemen. On behalf of my international colleagues of the Sympatico study group, it is my great honor to present our trial here at the ASH News. Ibrutinib combined with the Venetoclax in patients with a relapsed refractory mantle cell lymphoma. Primary analysis from the randomized phase 3 Sympatico study. Ibrutinib is the oral BTK inhibitor approved in many countries around the world for treatment of relapsed mantle cell lymphoma. Venetoclax is another oral BCL2 inhibitor that's also approved in multiple countries in the world to treat CLL and untreated AML. The combination of these two agents leverages complementary modes of action and has demonstrated synergistic anti-tumor activity in preclinical models of mantle cell lymphoma. Furthermore, in patients with a relapsed refractory mantle cell lymphoma, promising clinical activity has also been observed with the combination of the two in early phase studies. Therefore, the current phase 3 Sympatico study is evaluating the efficacy and tolerability of this combination Ibrutinib-Venetoclax compared with the Ibrutinib placebo in patients with relapsed refractory MCL. To avoid tumor lysis in open safety run-in phase, demonstrated that the two agents can be safely started together. Here is our study design. As you can see, Sympatico is a multinational, randomized, double-blind, placebo-controlled phase 3 study. Eligible patients who have relapsed refractory mantle cell lymphoma with 1 to 5 prior lines of therapy were randomized at 1:1 to 2 arms. The combination arm is shown in blue with Ibrutinib Venetoclax, and the placebo arm with Ibrutinib placebo as shown in orange. As you can see, in the combination group, Ibrutinib was daily. Venetoclax was with the initial ramp-up to 400 and then continued for 24 months. In the placebo group, Ibrutinib was also daily, and the placebo was continued for 24 months. In both arms, Ibrutinib dose was 560 daily until progressive disease or intolerance. The primary endpoint was PFS by investigator assessment using Lugano criteria. Secondary endpoint include CR, time to next treatment, overall survival, and overall response by investigators. So the primary endpoint, investigator assessed PFS was significantly improved with Ibrutinib Venetoclax versus the placebo group. As you can see in blue, the combination group separated with the placebo curves with the time nicely. The median PFS for the combination group was 31.9 months, which is much longer than the 22 months in the placebo group, and the hazard ratio is 0.65, and p-value is significant. As you can see on the left panel, the overall response rate of the combination group was 82 in blue and versus 74 in the placebo group. This is not statistically different. However, if you look at the CR rate, and the CR rate was 54 in the combination group versus 32 in the placebo group, and this is statistically significant. On the right panel, the curves of duration response separated nicely, and also the median duration was 42.1 months in the combination versus 27.6 months in the placebo group. Overall survival was numerically improved at this interim analysis. As you can see, almost initially the two curves are superimposed on each other. At around month 16, Ibrutinib in blue, Venetoclax combination arm stays on the top. But the odds ratio is 0. The median overall survival was 44.9 38.9 months in the combination group versus 38.6 months in the placebo group. Hazard ratio was 0.5, however, p-value was not significant. This slide shows the safety, which is consistent with the new AEs with each agent. The median overall treatment duration for the combination group was 22.2 months versus 17.7 months in the placebo group. On the left table, you can see that the grade 3 and above AEs was actually pretty balanced between the combination and the placebo group. The same applies to the serious AEs, actually 60% each in both arms. So the similarity, the balance also applies to AEs leading to discontinuation, AEs leading to dose reduction, and AEs leading to death. And also tumor lysis syndrome. They are all balanced between the two arms. On the right, AEs, adverse event of any grade, the most common include diarrhea, neutropenia, nausea, and fatigue. On the bottom figure, the most frequent grade 3 and above AEs included neutropenia, pneumonia, and thrombocytopenia, and anemia. Please note that the atrial fibrillation rate was identical in both arms at 5% each. In conclusion, Ibrutinib-Venetoclax combination achieved a statistically significant improvement in the PFS compared with Ibrutinib plus placebo. And this combination was with robust benefit across all sensitivity analyses. CR rate and time to next therapy was significantly statistically improved. Overall survival was numerically but not statistically significantly improved at this interim analysis. And please note, this is only interim, and we would have longer data. The safety profile of this combination was consistent with the new adverse events of each single agent, with no new safety signals observed. Overall, the addition of Venetoclax to Ibrutinib has a favorable benefit ratio in patients with relapsed refractory mantle cell lymphoma. In my personal opinion, this combination in the countries where Ibrutinib is indicated should be a new standard therapy for relapsed refractory mantle cell lymphoma. Thank you.
Thank you, Dr. Wong. Dr. Qasim,